Okay. Good morning, everyone, and thank you for joining me for the next hour or so as I talk about this very important topic of lung cancer screening. So lung cancer screening and screening in general is a very huge topic, but I'm going to attempt to at least scratch the surface over the next 40 minutes or so. So my objectives, my slides are not advancing. Hang on, pardon me. There we go. So my objectives this morning are to give you a broad overview, firstly for the justification for screening. Why should we screen for lung cancer? How did we get to this era? And what are the reasons for doing it? I realize the audience is composed of healthcare professionals as well as members of the community who may have had cancer or know someone who's had cancer, or patients or people who might believe that they or one of their loved ones might be at risk for lung cancer. So I'm going to try and provide some information for those people, and also for healthcare providers who might be interested in offering screening to their patients. So with that, I'm going to start with a couple of questions for you all to ponder. The first question I'd like to ask you, and I'm not going to have answers from the audience, you don't need to put it in the chat or anything, but I'm just curious what people think is the most common cause of cancer among women, excluding non-melanoma skin cancer, which is the most common cause of cancer but is curable. So which of the following cancers do you believe is most common among women? And I'll give you a couple of seconds to think about that. Okay, so if you were thinking breast cancer, that would be correct. Breast cancer is by far and away the most common cancer among women. Now, the next question is, which of the following do you believe is the leading cause of cancer death among women? And you might have guessed the answer to this based on the topic of today's lecture. But in case you didn't know this, cancers of the lung and bronchus are the most common cause of cancer death among women. So now I'm going to drill down a little further, and we're going to take a look at the magnitude of this problem, because the problem of lung cancer is actually a really enormous problem in our country and throughout the world. So just to reiterate what I was talking about before, lung cancer is the leading cancer killer of both women and men. And actually in 1987, lung cancer surpassed breast cancer as the leading cause of cancer death in women. So why should we screen, given that the rate of new lung cancers among women increased dramatically over the last 50 years? It peaked in 1998, and then it started declining. So that's a little bit of good news. Rates are declining. But there are still a lot of women at risk. Between that period that I just mentioned, roughly 50 years, the number of lung cancers among women increased nearly tenfold. So there are still a lot of women out there who are at risk for developing lung cancer. So just to give you a little bit more information on that, I'll show you some statistics. So here are the rates of cancer per 100,000 in the United States. And these are recent statistics that were released in June of 2020. So breast cancer, as you can see, by far and away, if you look at the green bar, which represents the rate of cancer per 100,000 individuals, breast cancer is by far and away the most common cancer among women. And lung cancer trails behind pretty significantly. And then there are several other cancers that I chose to present here, including some gynecologic cancers, as well as other common cancers like colon and thyroid cancer. But you can see that lung cancer is still the leading cause of death. So almost 1.5 times the number of deaths among women are caused by lung cancer than breast cancer, for example. And then if you just look at the sheer number of deaths in 2017, these are statistics from 2017, there were about 40,000 breast cancer deaths in the United States. And then if you look at cancers of the lung and bronchus, there were about 67,000 deaths among women from cancers of the lung and bronchus in 2017. So this is a really huge problem nationwide. Here are some statistics from the state of Vermont. Again, we have breast cancer, lung cancer, colon, etc. And the green bar represents the the number of deaths, and the number of cases, and the red bar represents the number of deaths. And again, you can see a similar trend where breast cancer far outweighs all the other cancers in women in the number of cases. But when it comes to the number of deaths, lung cancer makes up more than twice as many cancer deaths than breast cancer. And in fact, makes up more cancer deaths than several of the more common cancers combined. And I should mention at this point that the information that I'm providing here is by no means meant to diminish the seriousness and importance of other types of cancer in women or in the population in general, particularly breast cancer. I'm just trying to raise some awareness about the problem of lung cancer in the population because it is a very, very large issue. So now we have to stop and ask ourselves, why is lung cancer such a serious disease? Why does it cause so many cancer deaths? Well, here are some statistics, and I hope that I'm going to minimize this on my side because I have the video covering these statistics. But this diagram shows some data at which the stage of various cancers are diagnosed. And each bar here is color-coded according to how advanced the different types of cancer are at diagnosis. So the green portion of the bar indicates the percentage of cases that are discovered once they've spread to other parts of the body. So they've spread beyond the lung. And the red bar indicates the percentage that are discovered when the cancer has spread regionally. So it hasn't spread to other organs, but it's spread within the region where the cancer first developed. And you can see from this graph that lung cancer is almost always discovered either after it has spread to other organs in the body or after it has spread regionally. And you can compare this to other types of cancer, which are typically discovered earlier than lung cancer. And what this means is that the 5-year survival rate for lung cancer is much lower than that with other common types of cancer like breast cancer and colorectal cancer. So the 5-year survival rate for lung cancer is a little under 19%, whereas for breast cancer and colorectal cancer, the rates are much, much higher. So, this is directly related to the fact that a lot of lung cancers are discovered after they've already spread to other parts of the body. And in fact, the 5-year survival rate for advanced lung cancer is about 5%. So it's a really, really significant problem. So as with many cancers, patients with earlier stage, more treatable disease don't have any symptoms yet. Cancers that are discovered at a late stage are typically discovered only after they've developed symptoms, and those patients tend to have a poorer survival. So considering these facts, what options do we have to address the problem? So the vast majority of lung cancers, as you know, are caused by smoking, over 80%, at least 80%. And the best way to prevent lung cancer is to never have smoked at all, and that would be referred to as primary prevention. But this is simply not an option for patients who are current and former smokers. And these patients are frequently stigmatized, which is a huge problem. And they really feel as if they don't have any options. So what can we offer them? Well, one thing that we can offer now is screening, which is considered a form of secondary prevention, where we screen for the disease and we find it at an earlier stage, thereby giving patients the option of effective therapy that can increase their chance of survival. So here is a single image from a CAT scan or a CT scan that was done on a patient who has emphysema. So the black stuff here is the lungs, and the heart is this big white thing in the center. And these linear white structures are the vessels. And I've circled the lung cancer in this patient, and this was found at an early stage and was treated. So screening is a form of secondary prevention that we can offer to people who are current and former smokers. So what are the goals of screening for lung cancer, or for any type of cancer for that matter? Well, the definition of screening is the systematic testing of asymptomatic individuals in order to detect preclinical disease. So we want to find the disease before it becomes symptomatic. Without screening, diagnosis occurs after the development of signs and symptoms. Screening is not going to decrease the incidence of disease. Lung cancers that are detected with screening would have arisen irrespective of whether those patients were screened. What screening offers is the detection of cancer at an earlier, more treatable stage. And this is true of any screening test. And by treating cancers at an earlier stage, we can hope to decrease mortality. So now I'm going to talk about the history of lung cancer screening. And I'm going to start with this quote that was published in July of 2012 in the Journal of Thoracic Imaging. And this author writes that breast, colon, cervical, and prostate cancer all have established screening programs that are covered by insurers, embraced by physicians and the public, endorsed by professional societies and policymakers, and touted as critical public health measures as the US healthcare system strives to prevent rather than treat disease. Yet in the midst of this enthusiasm for early diagnosis, lung cancer has lagged behind with no approved, endorsed, or supported screening modality. So I'm just going to let you think about that for a second. So this quotation was published shortly after the release of data from the National Lung Cancer Screening Trial in the New England Journal of Medicine. This was released in 2011, and the title of the paper you can see is Reduced Lung Cancer Mortality with Low-Dose Computed Tomographic Screening. So the quote that you just saw was part of an advocacy effort to start pressing for lung cancer screening based on the results of this trial. This particular trial was preceded by smaller trials that showed a benefit for lung cancer screening. But up until this landmark publication, the evidence just wasn't considered strong enough to justify large-scale screening. So what came out of this trial? So I'm going to go into a little bit of detail because I think it's important to discuss some of the evidence for the trial to make the case for lung cancer screening. So again, this was referred to as the National Lung Cancer Screening Trial, or the NLST, which is what I'm going to refer to it from now on. And this trial randomized almost 54,000 Americans. Half of them got low-dose computed tomography or low-dose CT, and the other half got chest X-ray. And I should mention at this point that the reason why chest X-ray was chosen for the control arm of the study is because chest X-ray had been shown in numerous previous studies to have absolutely no mortality benefit for patients in terms of discovering lung cancer. So again, if providers want to screen for lung cancer, chest X-ray is not an appropriate modality to do so, and they should not be ordering chest X-rays to screen for lung cancer. Okay, so moving on to more information about the trial. The inclusion criteria for this trial was patients had to be 55 to 74 years of age. They had to have a 30 pack year history of smoking, meaning, so a pack year history of smoking means that you smoked 1 pack a day for 1 year. So someone who smoked 1 pack a day for 30 years would have a 30 pack year history of smoking. And if the participant was a former smoker, he or she had to have quit within 15 years. So if the person had quit 20 years ago, they would not have been eligible for this study. So those were the study criteria. The trial looked for a 20% mortality reduction in the low-dose CT arm versus the CT or versus a chest X-ray arm. So they were looking for a 20% mortality reduction. What they did with patients is they had them undergo 3 annual screening studies. So each person that was enrolled in the trial underwent a low-dose CT scan each year for 3 consecutive years. And then they followed the patients but didn't screen them for an additional 3.5 years. The study was terminated in October of 2010. The data was initially released in November of 2010, and then as you saw, the publication was released in August of 2011. I'm sorry to interrupt here, but I'm going to take a little sip of a beverage so my voice doesn't start to go. Okay, so what they found in the NLST is that there was actually a 20% mortality benefit in the low-dose screening arm, low-dose CT screening arm. And importantly, they also found that there was a 6.7% decrease in all-cause mortality in the low-dose CT arm. So that number is really important because what it means is that the trial itself did not increase the mortality rate. So being in the trial did not expose you to additional risk that would increase your mortality rate for most of those patients. And also those who were saved from lung cancer didn't die of something else. So this brings up the concept of overdiagnosis bias, which I don't have time to go into, but basically what it means is they were not diagnosing pseudo disease, other diseases or lung cancers that would not have killed the patient anyway. So those are really important points about this trial. Just for interesting information, just to provide you with some other interesting information, causes of death in the trial were in order of occurrence: lung cancer, other cancers, cardiovascular illnesses such as heart attacks, and then respiratory illnesses such as pneumonia that may have been caused by COPD, for example. Also, another important point from the lung cancer screening trial was that the complication rate was low. So among those with lung cancer, there was about a 10% complication rate, and most of those were minor complications, like limited hemorrhage from a biopsy, for example. And a lot of those complications were actually caused by the lung cancer itself rather than by interventions from the trial. And the complication rate among those without lung cancer was very, very low, less than 1%. Okay, and other important findings from the trial, perhaps the most important findings, were that in the low-dose CT arm, there was a much greater number of early-stage lung cancers diagnosed. So those were potentially treatable cancers. And there were many fewer advanced stage lung cancers in the low-dose CT arm than in the chest X-ray arm at the second and third screens. So what this means is that they actually were finding more early-stage lung cancers in the low-dose CT arm. So the important point here is that overall, there was a true decrease in the number of advanced stage cancers in the low-dose CT arm. So after this trial was published, there was a flurry of advocacy work to try and secure the blessing from an organization known as the U.S. Preventive Services Task Force. And they issue recommendations on screening tests that are typically used by the Centers for Medicare and Medicaid to determine coverage of payment for a service like lung cancer screening. So here's one example of that advocacy work that came about as a result of the National Lung Cancer Screening Trial. This was a letter that was addressed to the U.S. Secretary of Health and Human Services at the time, Kathleen Sebelius, and it was written by the Lung Cancer Alliance leaders urging coverage for lung cancer screening as an essential healthcare benefit under the Affordable Care Act. So here's just some of the text from that letter. One of the driving forces behind the Affordable Care Act was ensuring that all Americans have equitable access to healthcare, not just employed or affluent Americans. Failing to include lung cancer screening as an essential healthcare benefit in state health exchanges works against this driving force of the Affordable Care Act. It will exacerbate existing disparities vis-a-vis lung cancer. No one deserves to die from lung cancer simply because the ACA does not mandate coverage of lung cancer screening. So this letter was speaking to the fact that, low-income Americans wouldn't be able to afford to pay for themselves to have lung cancer screening, and therefore it should be coverage under the ACA. And they go on to say that considering the enormous life-saving benefit that equitable deployment of lung cancer screening for at-risk populations can represent, we strongly urge inclusion of lung cancer screening in the essential health benefits package for state health exchanges, et cetera. So this was the beginning of the era of lung cancer screening. Again, that was one piece of advocacy. There was a flurry of work trying to establish coverage for lung cancer screening. So what happened after that was in 2011, the National Lung Cancer Screening Trial was published. In 2013, the U.S. Preventive Services Task Force issued what it referred to as a grade B recommendation for annual low-dose CT screening. And basically what this means is that the benefits of screening outweigh the risks of screening. And that was established in 2013 by the USPSTF. And I should also mention here that the grade B recommendation is the same recommendation, the same level of evidence that is given for breast cancer screening with mammography. So lung cancer screening has the same quality of evidence as mammography. And then 2 years later, the patient Protection and Affordable Care Act required private insurers to start covering lung cancer screening without cost sharing, which means that patients shouldn't have a copay to get lung cancer screening. So it should just be covered as a required benefit. And then shortly thereafter, CMS, the Centers for Medicare and Medicaid, added a counseling visit, a primary care counseling visit, and shared decision-making to the list of covered services for eligible patients. So I'll take a minute here to talk about shared decision-making because this is an important concept for primary care providers and other healthcare providers who want to offer lung cancer screening to their patients. Shared decision-making is basically the process by which a provider and a patient talk about the risks and benefits of screening, enabling the patient to make an informed decision on whether to have screening based on personal preferences and based on the evidence that's presented to them for screening. So that's what shared decision-making is. And the reason why CMS covers this is because otherwise providers are not reimbursed for talking to their patients about it, and that can present an obstacle for providers to offer screening to their patients. So shared decision-making is a very important part of lung cancer screening. And it also provides a teachable moment for providers to talk to their patients about smoking cessation, which is also a really important part of preventing lung cancer. Here I'll mention that, there have been some more recent major randomized trials besides the NLST. I don't have time to go into a lot of detail, but there was a recent trial called the Dutch-Belgian lung cancer screening trial. Some of you may have heard of this. It's also referred to as the Nelson trial. The data from that trial were published in February of 2020 and showed a very, very significant benefit after 10 years of screening. The benefit was 26% mortality reduction in the screen group. And the multicentric Italian lung detection trial was another large European trial. The data of that trial were published in 9 of 2019, and they found a 39% reduction in lung cancer mortality after 10 years. So very significant benefit from lung cancer screening in those two trials. So now that we've looked at some of the evidence and a little bit of the history for lung cancer screening, let's take a close look at eligibility, because this is always a question without a simple answer in the United States because there are so many different types of payers. So I'm just going to go through each of these because I understand there are some healthcare providers in the audience as well as individuals who may be interested in lung cancer screening who are curious whether they would be covered. So under Medicare, lung cancer screening is covered as a preventive service, and they basically used the NLST criteria for screening and then extended the age range a little bit based on their own analysis of the data. So patients who are eligible for Medicare, ages 65 to 77, who have greater than or equal to a 30-pack year history of smoking, who are current smokers or have quit within the last 15 years, and who have no signs or symptoms of lung cancer are eligible under Medicare for coverage of lung cancer screening without cost sharing, meaning that you shouldn't have a copay. Commercial payers, because of the Affordable Care Act, cover patients who are 55 to 80 years of age, and they extended the age range again based on some other analysis of the data that came out of the National Lung Cancer Screening Trial, who have greater than or 30-pack year history of smoking, are current smokers or who have quit within the last 13 years, and who have no signs or symptoms of lung cancer. Vermont Medicaid basically covers lung cancer screening for the same group that are covered by Medicare, but the age starts at 55 and ends at 65, where those patients would become eligible for Medicare. So the age range is 55 to 65, but otherwise same coverage requirements as Medicare. The category that always becomes interesting and complicated in the United States is that of patients who want to pay for themselves to have lung cancer screening. So self-pay is limited for patients who do not meet what are considered group 1 criteria, which basically reflect the information that I gave you above. And I'm going to go into a little more detail on this in the second slide, but who do meet group 2 criteria. So the National Comprehensive Cancer Network divided patients into 2 groups to determine whether or not they should have lung cancer screening. The National Lung Cancer Screening Trial had some very strict criteria that were fairly narrow. So again, they included patients who were 55 to 74 years of age. And again, you can see that the age range was extended by payers based on some analysis of the data that came out of that trial. Greater than or equal to 30 pack year history, current smoker or quit within the last 15 years, no signs or symptoms of lung cancer. The NCCN looked at some additional data, and they broadened the criteria for screening and felt that these patients who had other risk factors would also benefit from lung cancer screening. So in the group 2 patients, or for group 2, the criteria were broadened to include patients who were 50 years of age and older. So you can see that the age was lowered. Greater than or equal to 20 pack year history of smoking. So shorter history of smoking, but these patients have additional risk factors that increase the risk for lung cancer, such as family history, occupational history, radon exposure, pulmonary fibrosis, chronic obstructive pulmonary disease, etc. So there is a category of patients who can benefit from lung cancer screening who are not covered by traditional insurance and by Medicare and Medicaid, who might also benefit from screening. So if you or one of your loved ones or one of your patients fall into this category, it would be worth thinking about lung cancer screening. And in some cases, insurance will actually pay for screening in this group of patients if the provider makes a good case for it. And then if that's not possible, you may still be able to get a prescription and you have to pay for it out of pocket. Okay, so now I'm going to talk about the process of lung cancer screening. So here I'm going to emphasize that lung cancer screening is not just one visit with your doctor and one low-dose screening scan. It's very important to follow through and continue the screening process as with mammography. Otherwise, you won't achieve the full benefit of lung cancer screening. So the first step in the process, obviously, is a visit with your primary care provider. And at that visit, you undergo shared decision-making. Smoking cessation counseling really ought to be part of that visit. And there are resources for smoking cessation that can be provided. And then the provider writes a script for a low-dose CT scan. And I should add here that in order to be covered under Medicare and Medicaid, the provider has to document shared decision-making. It's very important that that is documented as part of the visit. And also, there are tools that providers and patients can use to determine whether or not they should get screened. So this is not something that you have to do on your own if you're a provider or a patient. There are many, many tools online. In fact, this is a tool that's used by some of our own pulmonologists at University of Vermont. This was a tool that was placed online by the University of Michigan. It uses it's basically a risk assessment tool. And what it does is it provides information on why you should be screened, which is basically the information that I just gave you, the cost of screening, and some other things to consider. And it also includes a cancer risk calculator, a lung cancer risk calculator. So what you can do is input your personal information, and the calculator, you hit this use it button, you input your information, and then the calculator will give you an estimate of your personal risk for lung cancer. So that can be something that's used in the shared decision-making visit to help patients and providers determine whether or not screening is appropriate. Okay, so the next step in the process after you've had your primary care visit would be the low-dose CT scan itself. So for anyone who's claustrophobic, first thing I should mention here is that this is not an MRI scan. So what you see here on the left is a CAT scan machine, and on the right is an MRI machine. And you can see that the donut of the CAT scanner is much, much wider. The hole is wider, and the scanner itself is very, very narrow. So if you're claustrophobic, CAT scans are not a problem as they are for MRI. So again, this is not an MRI. There's no problem with claustrophobia. So how does the scan, what does the scan mean for a patient? So first, to let you know how short the visit is, it's very, very short. It's less than 15 minutes from the time that you enter the CT scan room to the time that you're walking out of the room. Is really typically about 10 minutes or less. There's no preparation involved. You can eat your breakfast, have your coffee, or eat your lunch, and come in for your scan. You don't have to fast. We do not place an intravenous line. No contrast is administered. There are no medications required. You can take whatever medications you're taking that morning or that day as you usually would. You don't typically have to change your clothing. If you're a female, you would be required to take off your underwire bra because the wire in the bra can interfere with interpretation of the scan. And the only thing that you really have to do is lay flat on your back and hold your breath for 10 seconds or less. It's typically less than 10 seconds. And then what comes out of that is a CAT scan that's interpreted by someone like myself, a radiologist. And this is an example of a CAT scan. I'm going to show you what we would see as radiologists when we're looking at your scan, just so you have some idea. So this is a CT scan of the chest. What you're looking at here is starting at the neck. We scan from the neck down through the diaphragm. And what you see here, this is the trachea, the air pipe. And what you see here are the lungs, these large black areas with the white things that are coursing through are the vessels. So this is a CAT scan, and what we do is we scroll up and down this CAT scan. As you see here, it's like looking at a movie, and we look for lung cancers, and we just go back and forth and back and forth. And that's how we do our analysis of the CAT scan. So after you've had your CAT scan, the radiologist interprets the images, and we use a system to interpret the images that's highly standardized. So the American College of Radiology, based on a tremendous amount of data, provides us with a standardized reporting system for lung cancer screening. It's referred to as lung RADS, which is lung report. I'm blanking on it now. The reporting and data system, and this is the most recent version of that. So basically what it does is it enables the radiologist to assign a particular category to their patient based on the findings that they see on the scan. So for example, if your scan is a category 1 or category 2 scan, it means that what the radiologist saw on the scan is very likely to be benign with a risk of malignancy of less than 1%. And fortunately, this is what the majority of patients have on their scans. So the majority of patients, they come in, they get their scan, they're either category 1 or category 2, very low risk of malignancy, and the appropriate follow-up for those patients is simply come back for another low-dose screening in 12 months. There are a number of patients who have scans that have findings that are probably benign, but not, they're still indeterminate, so we're not sure. And what happens with those patients is they simply come back for an earlier CT scan to see if that abnormality underwent any kind of change that would indicate that it might be a malignancy. And this is a slightly larger, a smaller proportion of the population, about 5%, still fairly significant. And then the remaining patients would have lesions that would be regarded as suspicious or very suspicious. And these are patients who have a higher risk of malignancy based on the findings on the CAT scan, and they would go on to have additional testing, for example, an earlier low-dose CT scan in 3 months, or maybe a PET CT scan. And then some patients would go on to have additional testing like a biopsy. And fortunately, these patients represent a small minority of the patients who are screened. So, just to come back to our diagram of the process, you have your primary care visit, you've had your scan, the radiologist has assigned your category. Again, patients who have category 1 or 2 lesions would just simply return for another screening scan in a year. Patients with category 3 lesions, the indeterminate category, would return for an earlier screen. And, this would simply require another prescription from the primary care provider, or maybe from a pulmonary specialist if the patient was referred by primary care at that point to a pulmonary nodule clinic, which we do have at UVM. And then the patients who are in category 4 or who have lesions in category 4, those patients would typically be referred to what we call a multidisciplinary team. So there is a team of pulmonologists, oncologists and radiation oncologists, thoracic surgeons, and radiologists like myself. And what we do is we meet and we discuss these patients and determine what the appropriate course of action is for patients who have lesions that are concerning for lung cancer, highly concerning for lung cancer. So I'm going to go back, and again, I want to emphasize the importance of not just having that one screen, but sticking with the annual screening, because this is important in allowing patients to realize the full benefit of screening. If a patient comes and has a screening scan, and the screening scan is negative, and then they decide, oh, well, I'm fine, and they wait for 3 years, that means we may have missed an opportunity to pick up a cancer at an early stage and treat that patient appropriately. So here's an example of a patient who was recently diagnosed with a lung cancer. Here's a CT scan, and this is in the coronal, what we call the coronal plane. So you're basically looking at the patient from the front, and we're scrolling through the chest back and forth this way. And this is a reconstruction of the data that is acquired by the CT scan. I'm going to play that once more. I'd like you to look over in this region while I scroll. And you can see that there's what we call a nodule. It's basically a little white spot in the lung that you can see in this region. And this was picked up on this screening CT. So now I'm going to show you the process that this patient went through. So this particular patient came in for a baseline lung screening CT in 2017. And the radiologist who interpreted the scan found a very small spot in the lung. We call this a nodule. And this nodule was just a few millimeters in size. The patient came back appropriately in a year for another screening CT, and the nodule had gotten a little bit bigger. And then on the follow-up CT that was ordered at that point, the radiologist said, well, this nodule got a little bigger, come back for a 6-month CT scan. So in 6 months, the patient came back and the nodule was yet a little bigger. For some reason, the patient didn't come back for the recommended 3-month follow-up at that point, and came back instead a little over a year later. And you can see that this was in July of 2020, so COVID kind of got in the way there. The patient may have come back in a year. But anyway, in July of 2020, the patient comes back, and indeed, that finding is even larger. So the nodule got even larger. At that point, the patient was referred for a PET CT scan, which was the next appropriate step in management. So what you see on the right-hand corner, in the lower right-hand corner here, is an image from a PET CT scan. And what we look for in the PET CT is to see if the finding is bright. And what that means is that whatever you're looking at takes up a lot of glucose. So it has a high glucose metabolism, and that's a marker of malignancy. So this patient was diagnosed with a lung cancer on lung cancer screening, and probably was supposed to have come in a little bit earlier, but fortunately, this cancer was detected at an early stage so the patient could be treated appropriately and hopefully cured. So now that we've discussed the evidence for screening, and we've established that now patients who are interested in screening actually have insurance coverage, so screening is paid for in the vast majority of patients, there are still a lot of obstacles to screening. And probably the most significant obstacle is that there's a huge stigma associated with smoking. Patients who smoke tend to feel as if they are not, that they're blamed for their disease. They feel as if their healthcare providers might not be treating them fairly. And so they might not seek help for their lung cancer or for their risk for lung cancer, specifically screening. And they may also have a fear of the results. They might believe that the treatment for the cancer is worse than the cancer itself. And overall, they might be hesitant to seek help for these reasons. So that's a huge problem that healthcare providers should try and assist their patients with. There's still a lot of skepticism regarding the evidence for lung cancer screening. Hopefully, presentations like this will help to dispel some of that skepticism. And we still have challenges in identifying eligible patients. And some of this is because of the, inadequate recording in the medical record of patients' risk. So, providers need to take a detailed smoking history from patients to determine if they're eligible. And providers can use the electronic medical record now to provide reminders for follow-up scans, et cetera. So some of these things are underutilized. Also, there's some difficulty in conducting shared decision-making because providers and patients might not be aware that lung cancer screening is available to them. So again, these are issues related to education. There are also issues with access. Some patients don't have access to a screening facility. This is something that's certainly the case in Vermont, where a lot of rural patients might not be able to drive the distance to a screening facility, or not believe that, you know, they have access to a screening facility. And then, of course, we have to appropriately manage abnormal results, and that really falls on the providers. So that is another situation where education is required. So because of all these obstacles, even though the evidence for lung cancer screening is very strong and lung cancer screening is available to a lot of patients, the rates of screening are still very, very low. So in 2015, the Centers for Medicare and Medicaid did an analysis and found that only 6.3% of eligible women in the United States actually were being screened for lung cancer. So there's still a lot of obstacles, and we have a lot of work to do in order to, you know, achieve more widespread lung cancer screening, more you know, wider adoption of lung cancer screening. And just to give you the comparison, this 6.3% of eligible women is actually slightly higher than the number of eligible men who were screened at that point. So now I'm going to take a little bit of time and talk about some of the future directions of lung cancer screening. So we have very good evidence, but there's a lot of work being done to make the case for lung cancer screening even stronger. So this is one example of how we can improve patient selection. So as I've already described, the National Lung Cancer Screening Trial used specific criteria for screening. So again, age range, 55 to 74 years of age, a certain smoking history, et cetera, et cetera. So the National Lung Cancer Screening Trial investigators are now refining their criteria and incorporating other risk factors like occupational exposures, family history, expanding the age range a little bit to see if they can better select patients who would be patients who would benefit from lung cancer screening, who would see a mortality benefit from lung cancer screening. And there are other models that already exist that are stronger than the NLST criteria. So let me show you how, you know, with this little illustration, how that might work. So if the little green smiley faces are patients who were eligible for screening, and the little blue smiley faces are patients who are ineligible for screening, using the NLST criteria, certain patients who were deemed not eligible for screening, according to some other models, would actually see a significant mortality benefit from screening. So their little faces would turn blue, would turn green, and they would be eligible for screening according to these other models. And some patients who were screened or who were deemed candidates for screening by the NLST criteria, this green face here, if you use the other model to evaluate that particular patient, he or she would not see a significant benefit from screening. So there are several other models that can be used to determine a patient's risk, and some of those models actually perform better than the NLST criteria that were used in the National Lung Cancer Screening Trial. So again, the NLST investigators are refining their criteria based on age, smoking history, chronic obstructive pulmonary disease, occupational or radon exposure, family history, and presence of pulmonary fibrosis. Some other models include these. I'm not going to go into detail, but if you're interested in finding more information about these models, there are online tools available right now. For example, here, let me just move to the next slide. Oops. Actually, it would be the next slide. So for example, one of those models is called the Bach model. And without going into too much detail, Memorial Sloan Kettering Cancer Center actually used this model to create an online tool that patients and providers could use to determine their risk of lung cancer screening. And using this tool, you can also determine whether or not you're eligible for screening under the current criteria that are used by insurance companies and CMS. Another tool uses the PLCO model, and this is the NIH website. So the National Cancer Institute of the NIH provides a lung cancer risk assessment tool. So if you're interested in screening, or if you want to know your risk of lung cancer, you can simply go to one of these websites and use a risk calculator. And I presented one previously in my talk called www.shouldiscreen.com, which also uses a more sophisticated risk calculator that you can use to determine whether or not you're at risk for lung cancer. There are also some further developments in terms of looking at actual lung nodule characteristics that can help us better predict the risk that a particular nodule is a lung cancer. So we can look at risk calculators that take patient characteristics, but there are also risk prediction models that look at the characteristics of a particular nodule that can help us refine our follow-up criteria. So for example, you can look at a nodule in a patient who had a particular smoking history, but if you add in other risk factors like occupational history or radon exposure or family history, that can inform your decision whether or not to follow that nodule more closely, or determine that that nodule is less likely to be a lung cancer and follow it less closely. And then some more sophisticated computer-aided systems are currently under investigation to try and help us look at nodule characteristics in and of themselves to determine the probability that the nodule is a lung cancer. And what we refer to that as is something called radiomics or radiogenomics. So radiomics is basically where we extract and analyze specific imaging features that are not detectable with the naked eye. And those features are looked at with computer tools. So, you know, the computer tools allow something called feature extraction. And the feature extraction can provide information on details of those lung nodules that we can't see, that may have prognostic significance and significance in terms of what treatments would be appropriate for patients, and even might identify characteristics that indicate that that lesion is more or less likely to be a lung cancer in the first place. And now some investigators are using these tools, you know, radiomics tools, and also applying machine learning or artificial intelligence to try and aid in diagnosis and improve efficiency. So there are a lot of, you know, studies underway to try and improve detection of lung cancer, you know, improve, you know, the fidelity of our screening, of our risk prediction models, and also improve the efficiency as the numbers of cases, you know, of patients who are screened continues to grow. So in summary, the era of lung cancer screening is now underway. We still face a lot of challenges, and screening rates remain low because of the obstacles that I described earlier in my talk. But there are a lot of promising new developments. We're refining our risk calculators, and we're also developing, you know, computer-aided systems for helping us detect nodules, determine the risk of nodules, and also, you know, refining our risk assessment to help, you know, widen the net for eligibility for lung cancer screening. So here are some resources for you. I'll end my talk with these resources. The American Lung Association, the American College of Radiology, the CDC, American Cancer Society, National Comprehensive Cancer Network. Any of these websites provides you know, information similar to that I've provided in my talk today. So if you want to learn more about lung cancer screening, there's a tremendous amount of information on the internet that you can access by yourselves. And also at UVM, we have a website, we have a web page for lung cancer screening, which also has some of these tools. So if you are interested in lung cancer screening, you can also go to the UVM website and find out more information for yourself. So thank you for attending my talk. It's been a pleasure for me to talk about this very important topic. And now I'm going to open up the floor for questions.